Hi, I'm Dr. Matthew Skinta. I'm a board certified clinical health psychologist and an assistant professor at Roosevelt University. I'll be talking today about contextual behavioral approaches to reducing minority stress among sexual and gender minority clients. Now, in terms of how this is organized, I'm assuming with the ADAA population and those of you watching that you're evidence-based practitioners, that you care about the science and how you apply psychotherapy. And I'm not proposing a wholly new model of psychotherapy for you to use. What I am doing is offering a framework that might enhance the work that you do with this population. So in terms of an overview of what to expect for the next hour, of course, given the current context, I'm going to touch a little bit on COVID-19 because that shapes how our clients are coming to us. Um, I'll talk about structural limitations to an evidence-based approach to minority stress therapies. And what I mean by that is, for those of you who are already conducting a careful functional assessment, even though your curiosity was piqued to attend here, you may be thinking, why do I need to factor in additional information? What am I missing just doing a good ipsative evaluation of each client? I'll discuss scientific foundations of minority stress theory, as well as the identification of common factors that could make for good treatment targets. And I'll weave this in through the lens of process-based CBT. That is to say, when we think about the evidence-based techniques we have and the corresponding transdiagnostic symptoms that arise, how does this propose a model going forward that will best allow you to fold these recommendations into your practice? And specific contextual behavioral models that could serve as helpful guidelines for that. So it is important to consider that when we think about COVID-19, often we think about the daily limitations our clients are facing. We think about mask wearing or lack thereof, fear or concern of vaccination, whether or not individuals are co-housed in spaces where they could protect themselves. But it's also important to consider that within LGBTQ communities, your clients are going to be aware of a variety of ways that bias is increased during this time. So there are a number of nations, for example, Panama, Peru, and the area around Bogota, Colombia, that at the early stages of strict quarantine rules designated shopping days by gender. So Mondays for men, Tuesdays for women, and so on. This led to a great deal of police harassment and violence toward transgender people, particularly trans women. In part through the rallying of activists, this did lead to gender rules changing after only a week in Peru and after the first month in Bogota. But I've had difficulty determining that such rules have been eliminated everywhere in the world. Ulysses Rocateri, a young gay artist and activist in Belize, was detained for breaking curfew, but as an activist, both related to LGBTQ causes as well as HIV advocacy, he was well known to the police, and in the days before his death in a hospital, he attributed this violence and the beating that he received by police as due to his being identified as an activist. In Hungary, like in many countries, administrative powers were turned over to the executive branch of government because the legislature couldn't meet easily during COVID. President Viktor Orban banned changes to the sex assigned at birth on ID cards as one of the very first acts he took under emergency powers to reduce the spread of COVID. Obviously, something completely unrelated to the spread of COVID. So, there are a lot of ways in which, under cover of this, changes are being made. You can find examples of religious leaders globally of just about every faith blaming LGBTQ acceptance or the recent codification of marriage, for example, in Ireland, as a cause for the spread of the pandemic. So, all of these increase animus that might be experienced by your clients that they may be aware of. And this is only a partial list. Some of these are still unfolding. For example, in the Czech Republic, where initially city halls were closed to business due to COVID, they then moved marriage certificate applications online, but legal domestic partnership registrations are still on hold and cannot be conducted that way. So there are a lot of subtle ways that these are occurring around the globe. And you should try and be aware of what's affecting your local community, particularly when we think about populations affected by HIV that may need access for blood draws or for medication, or for trans individuals who may have care either for gender affirming procedures or for access to hormones affected during this time. So let's think about other parts of the context that shape psychotherapy with sexual and gender minority clients. So, according to research conducted within the US, most clinicians will have some LGBTQ clients in the life of their practice, yet most will also have received no specialized training in how this should look. The literature in many countries, particularly in the US, emphasizes an affirmative approach, meaning non judgmental, unbiased care. Yet simply not mistreating a client doesn't advance the standard of care. It's also important to consider, I should add as a caveat, that when I talk about affirmative approaches, this does have a somewhat different meaning in communities of providers who work with lesbian, gay, bisexual, or other sexual minority clients, where it's taken in this way, versus gender minority clients, where there's different norms and affirmative practice often does actually imply a more comprehensive or knowledgeable approach to centering the experiences of the client. And so, for those of you who practice cognitive behavioral approaches and who do conduct a functional analysis with your clients, what does it mean to think about incorporating elements of cultural diversity? Uh, I like this quote from an article by Hayes and Tormino in 1995, where they noted that cultural practices are behavioral events considered in terms of their prevalence in a population and analyzed in terms of contextual features that affect the social propagation and maintenance of these behaviors. Now, how do we decode that? In other words, we don't stop thinking functionally when we describe cultural differences, though we consider that belongingness in a group is a relevant context to consider. Um, in the ACT tradition that I'm primarily trained in, when we're conducting a functional analysis, we're always thinking about behavior as an act in context. Our actions don't necessarily mean the same thing in a different place. And so when you're interacting with someone, either if the client perceives you to be cisgender and heterosexual, or if you are, or the world they inhabit, it's going to have an impact on behavior that you're going to have to factor into your work. The experience of expressing your gender in a way society punishes, or expressing same sex attraction that are responded to by others, is a social consequence that we always have to keep at the forefront with our clients. There are also structural limitations to an evidence based treatment of minority stress. Now, what I mean by this is that there are pretty steep shortcomings in the literature that guide what we do and don't know, and that affect the guidelines that you may have exposure to. Randomized controlled trials in the existing literature do not report on outcomes or participation rates of gender and sexual minority participants to a particularly high degree. This review by Heck in 2017 of NIH funded RCTs found no examples of tracking of gender identity beyond just male and female categories, and only a handful of studies that actually reported on sexual orientation. This is not to say that sexual and gender minority people don't participate in RCTs. It's just to say that there's no systematic tracking. And so it limits our ability to know if therapies work differently or are more or less effective when they're culturally competent. The treatment literature also overwhelmingly emphasizes HIV risk and those identities most associated with HIV risk. In part, this is because of funding priorities that have always placed HIV risk as the most important public health domain to consider when looking at sexual and gender minority people. There's only one RCT currently published targeting minority stress variables, which again was funded via HIV prevention mechanism and inclusive of only gay and bisexual identified cisgendered men. John Pachenkas is currently conducting a study with lesbian and bisexual identified women, uh, funded through a blend of foundations, but this is still forthcoming. Additionally, even though the NIH now has an office that tracks sexual and gender minority research, nearly three quarters of their portfolio is still comprised of research that targets HIV prevention, at least according to a review they released 5 years ago, though I haven't seen much to imply that this has changed a great deal in the past 5 years. There's also been an inconsistent back and forth in terms of whether or not federal agencies, particularly those dedicated to health disparities across groups, of whether or not they consider sexual or gender minorities to comprise such a population. Sometimes yes, sometimes no, sometimes the same agency has gone back and forth or across different mechanisms has decided uh, that this does or does not apply. So this begs the question, which you may be wondering, do we need SGM specific interventions? Well, gender and sexual minority individuals are subject to broad, well documented health disparities. This is inclusive of both psychological and medical disparities. There are studies that do demonstrate efficacy of non adapted treatments, and I think of this small study conducted by Beard. Um, but novel successful treatments exist that target unique sources of SGM distress. So, for example, there's Gary Diamond's work with attachment based family therapy that looks at the relationship between parents and children, both adolescent and adult, where there have been ruptures in that relationship that then ripple throughout other relationships in the child's life. Uh, Such therapies don't necessarily correspond to a given diagnosis. They target the transdiagnostic effects of minority stress and often aren't trained. The difference may even be more pronounced for those who experience greater minority stress. So, the less you've experienced bias, it may not make as big a difference, but when bias is high, it does. This is particularly important to consider given, for example, in the US, the efforts that our executive administration has taken in the past 4 years, frequently attacking not only trans rights, but transgender individuals' access to affirming healthcare or to equal access to providers. There are also some studies that suggest that even if the primary outcome of a symptom appears to be equivalent in a non-adapted or non-minority stress sensitive treatment, some sexual minority individuals report greater symptoms, periphery symptoms, and lower treatment satisfaction post-treatment. This occurred in the Beard study where they were looking at DBT applied for individuals across a variety of sexual orientations, but found that sexual minorities, particularly bisexual participants, felt particularly misunderstood and dissatisfied with their treatment and reported increases in other symptoms that were not the primary outcome. So I'll be focusing today talking about depression among SGM people. We know, for example, from the Institute of Medicine report that rates of depression among gay men are about 4 times what they are for straight men, among lesbians, about double for heterosexual women. I haven't found clear estimates for trans and non binary differences, though it does appear to be elevated as well. So it's important to consider that these ripple effects also affect while they are transdiagnostic in nature, do affect some of the diagnostic outcomes we see. So, what are common factors? Well, when we think about sexual minority stress, this was an approach that really took off in 1995, popularized by Meyer, that outlined, and there have been some additions over the years, uh, what appear to be some core factors that span the distal to the proximal sources of distress. Meaning, when you live in a society where you're embedded in constant messages or subtle actions or large actions that express some sort of animus toward your identity, you can't just measure this in one way. So when you look at older research, for example, from the 80s, there was a big emphasis on internalized stigma, particularly internalized homophobia. Biphobia and transphobia weren't studied until later, uh, with the assumption that if you adopted or believed these negative views about yourself, that might be a primary mechanism. Now this is broadened. There's also the role of stigma or that expectation of rejection, meaning even if I don't adopt negative views about my identity that I hear, I have an awareness that other people in society do. That awareness could be subtle. So I know that they're out there. I know that there are people that might make assumptions about, say, psychopathology or have stereotypes about histories of childhood abuse that they apply to their interactions with sexual and gender minority people. Or it may be more explicit. So, for example, we know through Glendale Russell's work that when populations or local political structures are debating the rights of sexual and gender minorities, that having that public debate, having it so clear that individuals hold those views and having difficulty evading the explicit recitation of those views actually adds to the stress that's experienced. Next is outness or concealment. Older studies focus on outness. Are you out or not? Excuse me. But as norms have changed, um, this has shifted what we've looked at in the research, because when you look at particularly Western or wealthier parts of Europe, North America, Australia, more and more people are out casually. Um, Even in context where there may be some bias, what becomes more important is the degree of concealment. Are there places in your life where you actively have to attempt to avoid having others detect your gender identity or sexual orientation? That appears to be a stressor. Next is discrimination. Obviously, if you're exposed to the range of microaggressions through overt forms of discrimination, such as hiring or housing bias, that's going to increase the stress that you experience in daily life. But as time has gone on, the minority stress model has also attempted to be sensitive to sources of resilience. One of the best supported ones is community connectedness, the degree to which we are able to connect with others who have shared experiences or hold an awareness that we actually belong to a group of people, and that the degree to which we're suffering or experiencing bias or isolation actually connects us to a common human experience. And I'll talk more about that a little later. This is related to a broad range of psychological symptoms, these distal to proximal uh, stressors. Um, these may be due to the way that they reduce emotion regulation. Mark Hudson-Buehler's conducted a great deal of work on how daily life stressors associated with minority stress chip away at our capacity to regulate strong negative emotions, but they affect our lives in other ways as well that I'll get into a little more deeply. This has also been extended to a gender minority stress model by Michael Hendricks and Rai Testa. So they conducted a large study in 2012 to see, does this truly hold up when we're looking just at transgender and non-binary people? What they and one of the concerns here is that when we think about that range of stressors, while they all certainly apply to gender minority individuals, we also know that there are much higher rates of violence, including physical and sexual abuse, rejection, discrimination, driven by gender identity and expression. This can range from being verbally assaulted. Laverne Cox just shared on social media not too long ago, while masked and socially distanced, walking through a park with friends, being accosted by a stranger, challenging her and asking about her gender identity, to sexual assault, mistreatment by police, or other forms of attack. So, what they found was that broadly, many of these factors do overlap for sexual and gender minority individuals. What I've done here in combining these approaches is that I've color coded. So what appears to have a lavender background are those factors that have been more strongly associated with findings among gender minorities. So while internalized stigma appears to affect the full spectrum, as well as the expectation of rejection, concealment, gender dysphoria, or that experience of discomfort in the body and with the body's gendered characteristics, has been more recently proposed by Pasgalupo in their work as a unique contributor that accounts for additional distress for gender minority individuals. Misgendering, when you're referred to by incorrect pronouns or the incorrect name, and then discrimination or violence, again, affects the full spectrum with varying degrees. sometimes affecting gender minority individuals more, sometimes more equal and more conservative parts of the world. Community connectedness is an important part of resilience for everyone, though pride in one's identity, is more strongly associated with resilience among gender minority people. I also include self-compassion as a source of resilience. While it's often not studied in conjunction with the broader minority stress model, a number of studies have highlighted the role of self-compassion as a source of resilience across various communities. The underlying mechanisms of action, well, we have emotion dysregulation, as I noted, which includes emotional ability, shame, may include volatile relationships. I'll talk more about that cascade of how relationships are affected later. And then these in turn lead to psychological or adverse psychological or physiological outcomes. So this is the core model that we'll be referring to when we think functionally about how do you blend this with a case conceptualization for someone who's seeking treatment for, say, depression. So when we think about targeting the underlying factors, there are a number of approaches you could take to this. Uh, Many studies and many scholars have focused on that core piece of emotion dysregulation. That if we build up skills associated there in a way that's inclusive of minority stress themes and that targets meaningful information for the communities we work with, that could be a good way for collective or omnibus treatment of the community. Colleen Sloan and colleagues have done a great deal of work around DBT and working with transgender communities. Again, regardless of diagnosis, this is not DBT because individuals meet criteria for borderline personality disorder. This is DBT intended solely to bolster the emotion regulation skills in the community. You can find some examples of MBCT being used. Uh, a handful of pilot studies related to ACT, and this list would be a little longer if we included those that were specific to um, HIV-related outcomes, such as medication adherence, and adaptations of the Unified Protocol, which is the foundation of the RCT I mentioned previously that John Pachankas has done, which incorporated that into a treatment protocol that folded in a number of these minority stress themes and educating participants or clients into a better understanding of how minority stressors might affect their ability to cope, be resilient, or handle stress on the day-to-day basis. Increasingly, though, researchers have noted that all of these targets, that entire column of stressors that I had up previously, provides us with a source of meaningful targets that we might attempt to ameliorate, as opposed to underlying factors alone. Brian Feinstein wrote a phenomenal piece this past year, for example, describing how we could break down rejection sensitivity and think about the different ways that individuals guard themselves against bias from others as an important target, as that poses such a barrier to relationships uh, throughout an individual's life. It's also worth thinking about what's missing from the model. So if we consider this the only thing that matters, what what might not be captured? Intersectional approaches, I think, are the most important. So the combination of racism in particular is absent from the model as typically presented. And we do see differences observed by race. One trend in some studies, for example, is that white cisgender participants may deny systemic bias to themselves, even when objective raters disagree. We know that sexual and gender minority people of color better identify systemic bias, but intersectional themes aren't often highlighted. So, what would we need to do? How would we tweak this model to also bear that in mind, knowing that when we're working with sexual and gender minority individuals, we're also working with Black, Indigenous, and other people of color? So, when we look back at this model, um, we might consider that with internalized stigma, there's also internalized stigma regarding unique race-based SGM stereotypes. So, not just a stereotype about what it means to be a trans woman or a bisexual man, but what does it mean to be a Black trans woman, to be a Latinx bisexual man? Expectations of rejection. So, not only anticipating rejection from others, but what about the anticipation of racism within SGM communities? Or, and this has received some study, particularly with among gay and bisexual men, but the phenomena of sexual racism, or the ways in which uh, racialized sexist attitudes or stereotypes come to play in social venues, on dating apps, the meaning of concealment in POC communities. So, does an individual who holds multiple minoritized identities then in turn conceal their identities in different ways across different parts of their life? And does that serve as a stressor that they'd like to explore in therapy? Misgendering, when we think about the additional microaggressions, and this may be an exacerbator of gender dysphoria as well, but the microaggressions that go hand in hand when we think about racialized stereotypes about how men and women should appear that trans and non-binary individuals are subject to, particularly when we think about phenomena like misogynoir or the specific type of misogyny that occurs in response to Black women. And then we know that rates of violence are higher towards sexual and gender minority people of color. When we think about bolstering community connectedness or sources of resilience, this includes connecting with SGM communities of color. So, are we being mindful not just on how we're helping our clients connect with their communities, but to communities that reflect all of their selves? Pride in their whole identity, meaning incorporating all of these factors. There are some critiques, and the most important I think I'll highlight before we move on is that Meyer noted in a recent article that psychotherapy for minority stress targets internalized problems, but these are societal in nature. So notice I'm talking about experiences of the individual and how we might treat this in psychotherapy with individuals or with or in group therapy. Uh, but it's important not to forget that as we adopt these as treatment targets, we don't want to neglect the need for strategies that target the source. These come from societal animus. This is because we live in a society that's biased that individuals are struggling, not because there's anything innate or inherent in them as individuals. We're putting a bandage on a wound that society causes, not something that's a flaw with an individual person. So, how do we incorporate this into our treatment planning? So, historically, CBT therapies, as I'm sure you know, have evolved as manuals based on diagnoses. So, manualized treatment of depression, for example. Process based CBTs have been proposed as a way to ask what are the core biopsychosocial processes presented by the client that should be targeted, given their goals in the current context, and how might those be most efficiently and effectively changed? So, when you think about common therapeutic processes that we might use across diagnostic categories like behavior activation, mindfulness, exposure work, what would a process based view of minority stress factors look like? So, I want you to hold a case in mind. So, Charles is a 33-year-old gay Black man who struggled with depression since adolescence. He describes episodes consistent with major depressive disorder occurring every 3 to 5 years, though his daily life otherwise is colored by dysthymic symptoms such as sadness, rumination about past losses, and relationship ruptures, as well as loneliness. The gay men in his social circle he dates are often white, which leads to additional misunderstandings and microaggressions in response to racism in the media. And though infrequent, in his occasional attempts to meet men through dating apps, he's also encountering racialized fetish talk. This worsens his mood and leads to greater feelings of isolation. Add intake, presupposing that he meets criteria for a major depressive disorder, and you may have tools that you always or that you already use to treat depression. You might consider that in addition to those standard self report measures, You could include something related to the experience of racial microaggressions. There are a number of scales out there, or measures related to the experience of LGBTQ plus microaggressions, such as the sexual orientation or gender identity microaggression scale, the SOMS or GIMS by Kevin Nadal. There is an LGBT people of color microaggression scale, though I would add that a significant limiter of it, I believe, is that it emphasizes both racialized microaggressions that occur in LGBT spaces, as well as anti-LGBT microaggressions that occur in spaces among people of color. It doesn't necessarily capture the nuance of the places those overlap, such as when I was talking about sexual racism or other stressors that we know that some uh, SGM people of color are experiencing. So when you're developing a psychosocial history, you might also consider specifically asking about meaningful landmark moments, such as coming out to themselves, to others, parental responses to coming out. Um, okay, so this is oh, sorry, I stumbled a moment. And for those who have partners who ejaculate, you might also consider HIV-related experiences in PrEP use. So this would include bi and trans men, as well as perhaps trans men or women who also have sex with partners who ejaculate. If you're working with a gender minority client, so Charles was described as cisgender, but with a gender minority client, you might also consider uh, important moments such as um, onset of puberty blockers, of hormone therapy, and any medical procedures, gender affirming procedures that have either been accomplished or are desired. So, first, let's think about core processes like emotion dysregulation or psychological flexibility. So, we would assume from Hotzenbuehler's work that to the extent that Charles is affected, you might see ineffective or maladaptive responses to strong negative affect. Emotion dysregulation, emotion regulation is a universal mechanism. So, this contributes to a number of types of disorders or types of dysregulation. We know that it's most elevated on average among SGM people, or more elevated, and therapeutic responses could begin with labeling emotions, exploring their functional impact, self-soothing skills, or SGM adaptive protocols like the ones I'd already mentioned. For our client, we might consider the role of rumination in depression that he's described, which may benefit from an introduction to mindfulness skills. So you might want to ask yourself, to what extent are intrusive or depressive thoughts consistent with sexual orientation rumination? This is a concept that's been written about. I've seen primarily actually in the OCD literature as well, where specific worries become sources of rumination that have to do with the consequences of being out in the world. Are there cognitions that may reflect internalized homophobia that could be a target for cognitive interventions such as cognitive reappraisal or cognitive diffusion work? And we could explore the experiential impacts of these thoughts and subsequent behaviors and affective responses for Charles. So, what happens to him when something has occurred or he's faced a reminder about negative views that he's held for himself in the past? Common ones that arise may be that I'll never find love, that it's inevitable that I'm exposed to HIV. All of these are fears that may come up and refer to internalized stigma. In thinking about rejection sensitivity, sort of the other side of the expectation of the expectation of rejection. Rejection sensitivity is that expectation that others are going to respond to one's sexual orientation or their gender identity by interpersonally rejecting them. So when you're on guard for this, when you're watching for this as you move through daily life, this includes interpreting ambiguous responses as signs of rejection. So I wave, you don't wave back. Is this because a situation came up the other day where I was outed? Is this unrelated? Establishing this has been established as a transdiagnostic risk factor for both gender and sexual minority clients. Therapeutic responses include exploring interpersonal patterns of behavior, reinforcing disclosure and vulnerability in session, and practicing new behaviors outside of session. This is also something that's been targeted by the parental relationship therapy I mentioned previously. So, how do we do this? How do we target these behaviors? Well, I think one of the most important things that have to be considered with rejection sensitivity is the therapeutic relationship. While our clients may hope that we're on their side, that we're caring, that we're compassionate, the same habits of watching for or being unaware that we're tracking the other person's responses as signs of rejection are going to be carried into therapy with us. So, this means that a therapist's disclosure of their own status as a gender or sexual minority may be an important contributor to the working alliance, although there's not, of course, data that such is true if you're emphasizing your heterosexual or cisgender identity. We do know from some literature that SGM clients may express a preference for CBT oriented therapies, though therapy that does not specifically incorporate sexual or gender identities more often described as unhelpful in literature on the therapeutic relationship and therapy outcomes. Personal disclosure with SGM clients may serve as an important role, or it may serve an important role in modeling and normalizing experiences. If our client is not that out, or our client is not that connected with the community, they have no way of knowing that an experience that they've just had, or they have less a way of knowing that an experience they just had, is something that is very common to other people who are sexual and gender minorities. If you know from your own lived experience that that's the case, being able to disclose this or discuss this with the client can be incredibly meaningful. Finally, there's some work by Alessi looking at the working alliance and the role of the real relationship. So, in working alliance literature, there's a construct and a scale of the real relationship that looks at separate from the working alliance. Is the client perceiving you as genuine, authentic? Do they see you as, how do they see you and relate to you as a real person in the room, separate from the work you're doing for them? In Alessi's work, there's an interesting phenomena where the real relationship, while not wholly overlapping with the working alliance in the general population, uh, does seem to have incredibly high correlations among SGM people. In one of his reported studies, well over 0.7%, or the well over zero point 0.7, meaning that we may be looking at a type of relationship where this is basically the same factor. Our SGM clients want you to be authentic. Our SGM clients expect you to be able to be a whole person in the room, and they're evaluating that as an important piece of therapy in a way that your heterosexual cisgender clients may not. And so, as you think about tools that you might use or incorporate into a cognitive behavioral therapy, consider the literature on functional analytic psychotherapy or CBEST, the cognitive behavioral analysis system of psychotherapy. These both include ample literature on the types of therapist behaviors that might be used to enhance the relationship or enhance a felt sense of genuineness in the room. So I'm going to talk just for a moment about functional analytic psychotherapy because this is the approach I take and train, and this is a helpful tool that I've found in my years of experience, both supervising in a training clinic as well as in private practice with SGM clients. So, for those of you unfamiliar, FAP is a neo-Skinnerian approach to considering the therapeutic relationship. So, it's applying the standard rules of a functional analysis to what's going on between you and the client. It's a close cousin of ACT. So, the development was inspired by early presentations back when Steve Hayes was still calling it comprehensive distancing. And it began in part as an attempt to better understand the master clinician. So when Mavis Tsai and Bob Kohlenberg were elaborating what FAP was supposed to be, they were thinking about the fact that when you look across therapeutic outcomes, you can find a number of instances where individuals are symptomatic prior to therapy and then are experiencing worsened symptoms, or and then for some clients, sorry, uh, they really experience thriving. So, while not every client or not every clinician often sees this, for some, therapy is a revolutionary experience. It changes their life. They flourish in a new way. And so they were attempting to look at that. Why is it that with some master clinicians, you often, or more often than not, see this thriving response, whereas the baseline is just remittance of symptoms? So they were attempting to study that and looking at the moment to moment reinforcement of natural closeness that occurred in therapy. In FAP, these are the only label you need to learn from the jargon there is CRB. So FAP takes a functional approach of labeling behaviors that are distancing or maladaptive or associated with symptoms as CRB1s, and those that are functional, those that promote and are mutually reinforcing with the therapist of vulnerability and closeness as CRB2s. CRB1s that are common among sexual and gender minorities include limited or unskilled labeling of emotions or tracking of internal sensations. If you experience a great deal of dysphoria, or if you've had to hide a lot of features of how you respond to the world, then it makes sense that your ability to tact those internal experiences is going to be reduced. Concealment of emotional responses. Uh, an under-rehearsed ability to express clear needs. And then finally, you might see an avoidance or self-censoring of thoughts or experiences that emphasize the role that their gender identity or sexual orientation play. This could be fears about body image or disclosures of attractions as they come up. CRB2s that you would want to watch for would be accurately labeling one's emotions, feelings, and values, a transparent disclosure of boundaries or needs, and the ability to openly and reciprocally express emotions, including content related to gender identity, sexuality, or attractions. So when we think back for our client, for Charles, you would need to be very aware of your own biases and comfort. How are you at discussing sexual orientation or sexual content? What is your comfort level if you are not a Black provider in discussing race? Avoiding generic or neutral responses when uncertainty arises. I mentioned before, one of the key hallmarks of rejection sensitivity is the perception of ambiguity as rejection. So, if that is the training history that a client is meeting you with, then consider that you might want to be more emphatic or more emotive or more responsive than you would with other clients. You might also consider that if your standard repertoire, whether the client is using slang that you're not familiar with, describing a community event that that you may have not heard of before or find surprising or confusing, um, that if you have a habit of retreating, of doing a therapeutic nod, that that may be perceived as rejection. So this is also a challenge for you as the clinician to lean in and openly share your points of confusion or uncertainty. I can see how hurt you are by what your friend said, and I feel like I'm missing something about the implication for why it landed so harshly. This feels important to me. Would you be willing to walk me through what it meant for you? This is how it could look to do that. We also want to consider the role of shame. When we look at work, and I haven't covered it here, though Kevin Nadal's written extensively about common microaggressions that sexual and gender minority individuals are subject to. Most of them are attacks on the self. Most of them imply that there's something wrong, something pathological, or something disordered about the individual, that this is their experience. And this is a context that promotes shame or a negative affective response to the self, often accompanied by painful self critical thoughts or perfectionism or difficulty feeling safe in relationships. Historical patterns of familial or interpersonal rejection are also pretty common among gender and sexual minority clients. And we also know that early life shaming or rejection experiences put clients at particular risk for chronic shame. There was a phenomenal study conducted by Marcelo Matos and Sergio Carvalho and colleagues a few years ago, where they were looking at individuals who experienced depression and asked them about early shame experiences. What they found was striking. This was exclusively with cisgender men. So they found that with the straight men, they reported instances of shaming that involved a variety of actors, other children, different adults in the world, a variety of context, but about 80% of those reported by gay men who experienced depression were shaming experiences that involved a paternal figure shaming them. We might infer often about gendered expectations. So while the phenomena may be similar, and while we're going to bring similar approaches in therapy, the history may look different, and we may need to be prepared to unpack different sorts of histories than we're used to if you've primarily practiced these skills with cisgender heterosexual clients. Therapeutic responses to shame can include training in mindfulness, self-soothing, exposure to fears around receiving compassion from others and the self, or emotional repair work with rejecting parents. But shame doesn't only need to be tackled with something formal like compassion meditation, though that is a helpful skill. Um, Self compassion buffers the effects of bias for SGM adolescents across racial groups. We know that it may specifically buffer against the impact of internalized stigma on psychological well being. I did run a group with colleagues that were preparing for publication on compassion cultivation training. So I won't scoop that or reveal full findings here, but something to keep your eye out for. So when we think of our client, when we go back to Charles, consider Kristen Neff's framework of self compassion and the role of common humanity, or remembering that our suffering is not wholly individual. Charles may benefit from bibliotherapy specific to his experiences. There's a rich literature out there of experiences of Black gay men or other men of color navigating white spaces in the gay community, of navigating sexual objectification or sexual racism in white spaces. These may help promote that sense of common humanity if he's not meeting reciprocal experiences among his own friend group or in his home community. And though self compassion may serve as a form of opposite action to shame, um, we may think of compassion meditation as a helpful adjunct. So but meditative practices hold different meanings for different clients. So, like I said, you don't have to go this route, but if you do, you should explore whether or not the client feels conflict with existing religious practices. Do they have a history of trauma and intrusive thoughts or reliving experiences where visualization practices may elicit those thoughts? So be mindful of those. Um, it's additionally worthwhile simply because meditative practices are so common in many compassion manuals these days that if you're working with individuals such as transmasculine individuals that practice chest binding, then drawing attention to the breath may actually lead to a dysphoric experience. So remember that the breath is not the only tool that you can draw from. And be sure to consult manuals or seek consultation by trans or non binary providers around alternatives that can help to ground and be in the present moment uh, without, uh, without evoking distress in your client. So, as we think about integrating these factors, they're all really about exploring the relative role of minority stress in your client's life and choosing interventions that you can add to the toolbox you already use based on their symptoms so that you can enhance the treatment and allow for a more specific targeted treatment that targets how minority stress is fueling whatever symptoms are occurring. Our clients are the ultimate expert on whether or not their sexual orientation or gender identity is relevant or meaningful to discuss across context. So there is a dance to walk between open curiosity and an informed stance, as well as allowing the client to run the show and to drive therapy. Because when it comes down to it, is minority stress always a contributing factor to everything that you see in doing therapy with SGM clients? Not necessarily. While it's unlikely that your SGM clients have never experienced bias or exposure to biased messages, consider how you might present other types of conceptualizations as hypotheses to explore with the client. So, for example, you may, as you present the rationale for behavior activation, talk about cycles of positive reinforcement in daily life and how this is something that, when manipulated, changes the experience for most individuals as they go through their day, or for many individuals. Perhaps your way of wording is that you share that this is something that many clients have found helpful and that you'd like to invite the client to try. In the same way that you present a rationale without being overly hooked to it to all of your clients, consider adopting the same approach for discussing minority stress. And finally, remember your own stimulus value. A client may have a history of misunderstandings that lead them to over clarify or emphasize parts of their experience or details of the community when they're speaking to someone that's a heterosexual cisgender person. This doesn't necessarily mean that those are areas of concern or emphasis in the client's own life. I think of an anecdote of I often have colleagues assume that I only work with sexual and gender minority clients in my private practice, which has never been the case. But I noticed that that assumption was markedly stronger among heterosexual colleagues who um, who often took any reference I made to general experiences with clients to be experiences with SGM clients. So I began referring to my clients with heterosexual cisgender colleagues, labeling that these were straight cisgender clients. I then encountered colleagues who were asking me, "So you seem to emphasize when you're working with a straight client. Is is that because that has some meaning to you?" Unaware that they already had come into the room with stimulus value, unaware that this was something that was evoked by their heterosexual identity. So we need to be mindful of that as well. If you're a heterosexual cisgender clinician, then a client may not be introducing these themes because they want you to talk about them. They may be introducing them because they feel like it's specific and because experience tells them that they should add these caveats with you. So always being aware of your own presence in the room. So for final points, there are strong foundations. The minority stress literature is 35 years old. Um, so we have strong foundations on identifying underlying mechanisms, treatment targets, and high need populations within SGM communities. Advancing these treatments should be intersectional. So while you need to be mindful of a client's sexual orientation and gender identity diversity, you also need to be aware that they have other identities and that those intersect in unique ways that create entire communities in and of themselves in order to be truly culturally competent. And finally, therapies for gender minority stress may require attention to additional transdiagnostic targets. These can range from complex trauma to interoceptive awareness for those who have difficulty tacting emotions. Um, so, bringing this in mind and allowing this to enhance the practice you already do for uh, common diagnostic categories that you work with in your practice is only going to improve outcomes. I'll be sticking around for questions after the recording ends. But if future questions come to mind, feel free to contact me at mskinta@roosevelt.edu or to look for my books on this topic in the virtual bookstore. Thank you.